So good afternoon. So big team. You want to stay? Yeah, you can sit here.
We have some
You will able to see, but don't. You will not able to participate.
Hello.
We have some volunteers. Scenario लेने दो वाले. Scenario तो. Okay. ठीक.
Okay. Okay. They are looking in a pump. We'll see the circuit.
On कर दी. So.
Speak in mic so that everybody listens downstairs.
Hello.
Okay.
Hello.
Yeah.
Keep your mic on and speak. And those who does not have mic, they want to speak. Yeah, there is a hand mic, so you can speak on that. Okay. So that everybody gets benefited. Everybody listens to them.
You both will take care of ventilator, and you both will take care of ECMO machine, and we'll take care of cannulation. If anything has to change, we
We'll change.
will change. And you have to stay at.
You'll overall.
You also has to go missionary. Check for blenders and oxygen and those connections.
Intelligent ideas.
No, we
Observe
didn't practice in
pressures.
the morning.
Bus.
This is a pump. This is a oxygenator. That's it. The blender is coming.
Bus. Initially, you have to note the
Okay.
pressures.
Should I start?
Yeah.
Yes.
Sir.
Thank you. Okay.
282, 280.
Okay, sir.
So this is the same child who had underwent an ECMO. Is an immunocompromised child, and because he was on immunosuppressant, and then he is ARDS, and he went on ECMO. On day 3, he developed there was some kink in the venous line, and because of that, he had a bradycardia transient episode. Recovered well. Again, day 8. The filter got blocked because of there was some water in the filter, and because of that it got blocked, and the sweep gas was not going, and that's why he developed a sweep gas failure, and again he had an episode of bradycardia. The child is lucky, never arrested, okay, but he was near arrest. Okay, that is what has happened in the last 2 days. Now the child is doing okay from that episode. Today is day 12 of ECMO, okay, and these are the parameters what you can see. Overnight, when I joined duty, heart rate was around 95, 96. Overnight rate has increased slightly to around 105, 106. Otherwise, all parameters remain more or less same. Okay. So I had an uneventful night. Now it's over to you. I will go and rest.
Any temperature, sir? Rise in
Sepsis.
temperature?
No,
Rising.
temperature, everything is fine.
Okay, last ACTs were normal. Any fluctuations in ACTs or APTT?
Last SCT was 170.
170.
Yeah, APTT was 70. APTT 70, ACT 170.
Okay,
Other
sir.
Anything else you want?
CBC.
CBC.
Urine
CBC,
output, sir?
CBC today's report has been sent, is still awaited. Yesterday the hemoglobin was around 10.6 and platelet count was around 70,000.
Urea creatinine, sir.
Urea creatine normal. Creatine was 1.1 and urea was around 40.
Urine output, sir?
Urine output is around passing around 40 ml per hour,
Okay.
40 to 50 ml per hour.
Procalcitonin is been in the.
Not done. If you want to send, we can send it, but there was nothing suspicious, so we not send it.
So any change in the
Only
pressures in the
No,
last
circuit
night?
pressures and RPM flow remains the same.
Any return issues? No flow fluctuations?
Chattering.
Initial flows, how much, sir? It was? Flow rate?
Flow remains same. Flow RPM remains the same. up till
It
now.
was similar.
Yeah.
Now it is 1.3 liter
1.2
flow
liter
rates.
flow,
It was
3700 RPM.
Any history
Okay.
of chattering?
Material make.
छोड़ दो.
Can we uncover the issue?
Color.
chattering of. Okay.
There is
Okay.
You check
There
the
is chattering.
ventilator. These people will check the.
Candles.
Okay.
Yeah, so looks
Okay.
fine.
now the flows are okay.
See the monitor.
Monitor is okay.
Pulse.
There is
Yeah,
minor
yeah.
chattering.
6.19.
The colors
What
also
is
good.
that?
Which one?
Main issue is static.
That is
Pressures are
peripheral
still
and
okay.
core temperature, I think.
Okay, that's fine.
Now the flows are okay.
So no pressures.
Close.
Everything is looking good at present.
No change in RPM. No change in delta P.
No change in the flow.
Delta
No,
pressures are okay?
Pressures
Yes,
are
okay.
okay. The same as
P1
the
also
before.
negative. Everything
No,
is
no,
good.
there is
Flow is
minus
getting
flow.
low.
Flow is getting
Flow is
reduced.
getting
Flow
low.
is getting low. There is
Flow is getting low.
very much fluctuation in the flow rate.
Yeah.
Chartering of circuit is there.
No,
If you
no
touch it,
chattering.
then it will always do
Yeah,
that.
chartering is there.
You need to see.
Chattering,
No.
but no
Catering.
change
Yeah,
in saturation.
chartering is
Catering
there.
it
I think
is.
So
chattering
I
is
put
there.
It
So
started
Catering is
chattering.
decrease
Yeah.
the RPM
Decrease
and
the
give
RPM.
flows. Give
Decrease the
fluid,
flow.
300 ml fluid bolus, sir.
You want to give 300
Yes,
flows?
sir.
Okay.
I am decreasing the flows.
Decrease
Not
the
just
Just
bit.
reducing the RPM little.
Decrease the flows
Okay.
and give the fluid bolus.
Bolus.
Fluid blowers given.
Yes. And saturation going down 99.
One should see the flow rate.
Give the
1.3.
fluid bolus.
Pressures are okay.
but chattering is significantly
No,
happening.
no.
So we have to do some
Reduce the
imaging.
RPM. कहाँ से? यहाँ से होगा.
Reduce the RPM, sir.
Okay.
So RPM reduction.
SAR will decrease. We
RPM.
cannot change anything. We have to tell the sir.
That is
No,
flow
no,
is
there is,
decreasing.
There's
Flow is lot of
significantly
significant
chattering
flow drop.
happening. We need to
Ah,
reduce
it
the
should be
Yeah,
RPM.
we need to reduce the RPM.
RPM is 3700 fixed. Bring it to around.
Flow is not
Patient is
stable.
desaturating.
Tachycardia, desaturating.
Now,
not coming.
now
Give
the flows
200
are
ml
okay.
fluid bolus, sir.
Can we listen to his cardiac
Two more,
sounds?
100
Fluid given.
fluids.
We will
Yeah.
get it.
We need to
Testing.
check if there is any
Auscultate,
bleeding.
auscultate.
Check for the
Heart
tubing.
sounds.
sounds,
bleeding.
blood sounds.
If there is any blood
Blood
loss.
we can get the chest X-ray. Yeah.
We can send one ABG.
Hello?
Now the flows
Yeah.
are okay,
Flows are okay.
but
No chattering.
saturation is.
Can we increase the inotropic support of the
No,
patient?
it's
No,
not
not drops.
requiring
No,
any
Not
vasopressors.
requiring.
Not going.
Circuit pressures
Just-
are okay.
Tubes are
Tubes are okay. Same.
Chattering is
Pressures
stopped
are okay.
little bit.
Now the
But
flows
sta-
are
saturation
stable.
is still
How
low.
much is the flow?
1.3
Saturation
liters.
88 acceptable.
1.3 liters.
How much it was when you came?
1.27, 1.3, sir.
When you came?
Yes.
3.
It was the same.
It was more or less same.
3.
Okay.
Flow.
Heart rate is rising to 130.
Significant
Any-
chattering. I need to give
Flow is
much
decreased.
more
Ah.
Flow
fluid.
is decreased.
Patient is agitated or anything?
No, patient is sedated.
Chest X-ray and echo. we will get.
Any
Can we?
is present?
Okay. We have
Can we
called
go
for
on
an
the
echo.
ventilator?
Ventilator is
First
already
one.
100%.
Technician will come for the echo.
Yeah,
with
it's
the
already on
It
100%.
will take 10-15 minutes.
Okay.
Change
We
the
can in the
position,
meanwhile
neck
check for
positions.
auscultation of heart sounds, breath sounds.
Heart
other-
sound is fine. Breath
Yeah.
sound is fine.
Okay.
Are we on maximum ventilator settings?
Yeah,
Yes,
this
yes.
is maximum, 100%.
Does not require any way.
Until-
When we give the
Tachycardia
fluids,
and
that
hypotension.
Yeah,
RPM
Has he passed
improve.
They
any
should be
stools,
here.
like melanotic stools or anything that we know of?
In the night, no, you can examine and see if it is fast
Okay.
tool or no.
See,
Fluid bolus
Yeah.
is
How
Right.
much ECMO FAO2 we are on,
Yeah,
sir?
there is some
ECMO FAO2 on sweep, sir.
dark colored but
It's
not
100%.
melanotic. There is some
100%
dark
is
altered
only-
blood.
Outside.
Yes?
Excuse me,
Whether this
there
is
is some dark altered blood in his gauze, like from the stools. So it could be GI bleed.
So you think it is Malina?
Yes.
Need to
That
check
we
the
have to rule
hemoglobin.
out. We
So
have
what
to
do you
rule
want to
out.
do?
So we'll
Blood.
start transfusion. We will start pantoprazole
We-
infusion.
we'll
Yeah,
send
and
for
in the
hemoglobin.
meanwhile, we'll support his
We'll check.
hemodynamics.
Morning
it was
hemoglobin report just came. It was 7.6.
So he has significant drop in his
Significant drop.
HB. So he's having major GI bleed. So we'll at least target lower ACT.
Now we'll
We need to
transfuse
transfuse
blood.
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 Transfuse blood.
As well, if it's
And see platelet count
there is an
also.
anticoagulation, we stop.
We'll come down on anticoagulation.
pressures are
ACT
also
will
borderline.
maintain around 140.
Okay. So what do you want? You want to stop heparin?
Decrease the dose of heparin 20%.
We can
see
give
at
FFP.
Present time we will stop it
active bleeding.
and
I just want one answer.
Sorry.
We can stop at
You
least for 2
decide among
hours.
yourself and give me one answer.
We'll stop
No, no, not
transiently
bleeding, GI bleeding.
You want to
GI
stop
bleeding.
transiently?
and
Okay.
we'll
GI bleeding.
How much
transfuse the
time you
blood.
want to stop it?
At least 12 hours.
12 hours.
You want to
No,
stop
1
it
or
for
2
12 hours?
Yes, sir.
I'll do whatever you say.
So we can stop and
It is your patient.
recheck
Yeah,
ACT in 2
we'll
hours.
stop for
Heparin.
time being and check the
Then we will
circuit
reassess
hours and do the
4 hours
ACT,
ACT again.
and
after
then
four.
we'll decide. And by the time we will transfuse to PRBC to the patient.
Now we'll transfuse the blood and send the blood for
Check
coagulation,
platelets also.
coagulation profile.
And
We will stop
Do
heparin, repeat
thromboelastography.
ACT after 4 hours.
If any transfusions we need to give, we can give.
Right now we
We'll
are
transiently stopping the
stop.
heparin. We'll send for thromboelastography blood. Meanwhile, we'll transfuse the blood.
You transfer the platelet or blood?
Blood.
Blood.
You
Okay,
need to know the platelet count also.
Platelet count is 76,000.
So
In the
Any
meantime, we
history
can
of fever? No.
target
No fever.
1 lakh
No fever.
if it is active bleeding. So we can also ask
I
for
think there is
aspirin.
still activity because BP is 70 over 45. We give some
Any
fluids first
major
and then
bleeding,
arrange for
active
blood
bleeding.
transfusion as early as possible.
Okay.
We have
So
to give
transfusion,
blood.
we got a transfusion, we started a transfusion.
Started transfusion.
Okay, that's the thing. We have started the
We have started
transfusion, stop
transfusion.
the heparin, we send the blood for thromboelastography.
Sir, is tag available in our?
Platelets are little lower side,
So, Mike,
but still we don't transfuse.
BP is coming up.
Active bleeding.
what else you want to do?
It is around 70,000. So if I have to give platelets, I have to continue on heparin. So we'll give platelets and continue on heparin with the lower doses, maintaining
BP is
with
coming up.
140 around 140 to 150 ACT.
Is
L-
says no.
We should roll out hemolysis also. Hemolysis also.
Fever,
So I want one answer.
So
you
we
may
can
discuss and tell me one answer.
Tell
I
him,
want one
don't
answer.
tell sir. Yeah.
Sir, mic please.
So 70,000 platelet is okay. Currently we will not transfuse, we'll see the tech, we will give the blood and we'll look for the what is the cause for the bleeding here.
Okay. So you want to evaluate for the cause for the bleeding. So evaluate.
So we'll call for gastroenterologist.
You want to call a gastroenterologist's opinion?
Yes.
Colonoscopy.
Okay.
Endoscopy.
Endoscopy and colonoscopy both will be taken.
So I am a gastroenterologist. So what is the problem?
Patient is having
Suspecting
GI bleed
UG
and
bleed.
he's suspecting some
GI bleed.
upper
So
source,
we
upper
want-
GI source.
You to perform endoscopy and
So why?
Stop the
What is the reason for GI bleed? You feel? What is this all going on?
it's an ECMO,
What is the ECMO? I don't know.
extracorporeal membrane oxygenation.
So how does it
He's
work?
The patient is on anticoagulation, so we think that is the precipitating, but we need to roll out for his structural
So he's
lesion.
on heparin, you mean to say?
Yes.
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 Then why should I put a scope? If he bleeds,
If there
everything
is an
comes on me.
active bleed, we
Heparin
we
had
can
already
call-
stopped.
We
Then
can
again
we
it
can
is
take
falling.
control of
Stop the
source.
heparin, so you can safely perform.
So what is the APTT now?
APTT
Last APTT?
150.
So why should I do
ACT
it?
is not
ACT
150.
ACT 140.
ACT is 170,
Yeah.
but we have stopped
170.
heparin. So
But
it
how
must
much is
be
the
down.
APTT?
APTT.
I don't know what is ACT.
We'll repeat
Activated
APTT.
clotting.
Yeah, so once it
APTT
comes to
was
normal,
70.
you call me. I'll come and put in scope.
APTT is 2 times
Okay.
the base.
I don't want to put a scope here. The child is so sick. If anything happens, everything comes on my procedure. So you call me when your APTT is
Where is your
normal.
mic?
I'll definitely do it.
Now, gastroenterologist. We'll change the gastroenterologist then.
So we'll go for IR.
Sir,
Yeah, tag is your R is around 10, and I'll show you the tag picture. Just
R is evaluated.
yeah. Meanwhile, the tag report comes. You can continue.
Sir, we can
So
give
we need to
calcium,
resuscitate, that's it.
fluid and calcium.
In blood,
transfusion
BP is
is
improving
ongoing.
anyway.
APTT we have to check. Yeah. We're not, but at least send it.
Yeah, one blood is given. One pack cell is given. Yeah, we have reserved.
So what is the ABG now, sir, after transfusion?
अब क्या
Transfusion हो
ABG
गया
with
तो?
the oxygenation issue
हाँ
करनी?
तो बोला सर.
ABG, we have just sent it. I'm yet to get report.
Since we have stopped heparin, in the meantime, we'll monitor for the delta P.
Inside bleeding.
In case if the delta P is going up.
Hypovolaemia.
In children, physiology is different. No?
This is the tag.
This is the
Volume low.
Oh.
So,
time prolonged.
K is
Clotting factor
6.4. That's prolonged K.
fibrinogen.
It may be about
48.
That amplitude is lower. Amplitude is low means
Could be platelet.
Lysis 30,
Who is good at
DIC.
there's a DIC.
Lysis 30 is high. So we have to send.
So we have
We have to send fibrinogen.
So what you want to go ahead and do it?
give cryo?
So we'll give the
Cryo
cryo
we
will
give.
not give.
Cryo to we give. No.
We'll wait and watch. It's more sensible decision, isn't it? Okay. Anything else?
We have to find out the source for bleeding.
Source
no,
is there in GI?
during DIC if we do something,
The reason of DIC
Is it bleeding from anywhere else?
No.
we have to
check
check
it.
that.
But
Ralph tube
how
is
is
clear,
sensorium?
endotracheal tube is clear, catheter is clear,
Rice tube is clear.
yeah.
We should
We'll
aspirate the
check
rice tube.
Yes.
Have you aspirated rice tube?
Aspirate the rice
We
tube.
can predict
Then
syringe.
also you JB, bleeding. Then also gastroenterologist.
Give them syringe to aspirate and see. If rice tube is clear, then probably it's lower GI bleed, isn't it?
The reason of DIC has to be corrected.
Rice tube clear means likely to be lower GI bleed, isn't it?
Yes, sir.
No, upper GI bleed can also.
Upper in the lower.
The rice tube
right,
is clear,
not in
she
the
said, na?
stomach.
It must be the lower GI.
Yeah, it
Clear.
can be lower also.
Clear, okay.
No, sir, you discard.
It's clear fluid. No bleeding in the
No
circuit.
obvious
Aspirate
coming.
करके
Suctioning will cause more trauma.
See,
Okay. There's bleed.
For GA bleeding.
So now you think it's upper GI bleed.
Now we have to get a new gastroenterologist who is ready to take chances.
He's there to take chances. You can call him another gastroenterologist.
Because if we don't control the source, we'll keep bleeding. We can do some ablation or something. Try to motivate.
Diffuse bleeding also.
We need to
Yeah,
correct
it
the
is like
coagulation
Okay,
abnormalities. And then we need to think about the
But it is-
gastroenterologist, not correct.
Okay,
You
anything
are
else you want to
saying he is
do
on
before
heparin.
that?
we want to do PTN or APTT?
We can give FFP.
So you want new gastroenterologist? I can come as a new gastroenterologist.
Okay, I will come and see. As you told my colleague, child is on heparin, I heard.
Yes,
So maybe he is bleeding, and if we do any procedures on him, he will continue to bleed. And you will say if anything happens, it is because of the gastroenterologist. So we don't want to touch the patient.
We'll assure that it will not come to you, sir.
yes.
We'll check for
No protein.
we'll check for heat and factor 10A levels.
Have you done anything more than that? Have you just started pentoprasad drip?
Yeah, that's
Like
You
that,
started
From
that.
the beginning
Okay.
we started.
Anything else? Any other thing which you can control with without intervening?
Tranexo
So we can give sucralfate like
Yeah.
Reversal
PPI.
of heparin with protein. But
No,
But that will
No,
give
no,
that's not
That's not indicated.
no, it's not indicated.
Fine. So okay, so we'll stop scenario here. Your case is
Sorry.
now you know what was the case.
Yeah.
How anybody can just go step by step. What has happened? Any one of you can
So-
just.
So case of tachycardia, you should always alarm us that patient is having either fever, new sepsis, or anemia, hypovolemia.
What are your observations? Just let me know when you came here. Starting from the time you came. Take a mic and speak so that no, then people don't able to listen downstairs.
So when we came here, as you told, ki there is a slight increase in the heart rate, and by the meantime, flow started fluctuating. and then repeated chattering was there. So we looked for the hypovolemia and all. We have given some fluid. We looked out for the kinking that was not there. Then we called for an echo kit to assess that, and then we found that there is a melena. So that was a GI bleed. We didn't. So we ordered a tag, and then we decided to stop the heparin. While we did an RT section where also we found a blood. So
And patient had drop is actually, yeah, so patient has significant drop in his hemoglobin, so that suggests that there was massive GI bleed. So in case of ECMO non-anticoagulation, we have to be very vigilant, and we have to be proactive, correcting all the coagulation parameters, and transfusions as needed. Plus he's a kid, he has low reserve. And
Okay.
we would like to get intervention, but that was not possible. But we can, and our tag was showing DIC, so we'll try to correct coagulation parameters first and monitor his vitals.
And also to find out the reason of DIC with a mesh, maybe the disease related, maybe new sepsis, new infection that can also lead into the DICs.
Which are the areas you did good? What are the good points from your examination, collective examination?
Shattering we had find out, hypovolemia, and we had given fluids. Then we had decided about the blood, but we can't find out the site of bleeding initially. Later we make it out. Then we ordered for tech. We had stopped the heparin. Then
And I think
from tech we identified that it was DIC.
What are the areas you need to improve?
Clinical examination, like patient head to toe
Exactly.
examination.
I have
We
seen
focus more
first
on
2
ECMO.
minutes you spent in giving different roles. You look after ventilator care, patient care, ECMO console, etc. But I haven't seen that happening practically. Everybody was standing as such, except for the ECMO side people, they went there. But rest of the things I haven't seen practically happening. So from head to toe, especially the people who are allocated for clinical examination, if you have done that, long time ago you could have diagnosed melena, long time ago.
Right.
So after nearly spending 10 minutes on this, then you went and you suggested that and you went there. So discharging your duties and examining the patient all completely, thoroughly is very important for this also. Okay. So, yeah. And if there is any doubt, share it with your colleagues. As a team, you have to come out with the conclusive action.
So in this case, what next to do? In part of the management part, because
We have to continue on heparin.
so what?
If the bleeding is major, if the bleeding is major, you can
major,
you
obviously,
can
the
stop
BP
it
drop
till the
down and
hemoglobin comes up at least. With the hemoglobin comes up,
Stop the heparin.
sure. And with respect to the platelets also, though it is not intracerebral bleed, if it is a major bleed causing problem, still you need to keep the platelets high, above 100,000 with that. So single donor platelets, I would give in that situation. These two, okay. But scopes, they can also aggravate. You need to identify the cause, but passing esophagoscope again, it might aggravate a new bleed. That is also a possibility. It is not without risk. That risk also exists in that.
Volume loss. What?
I think
No,
Pranay wanted to
it was
exaggerate.
just drainage canal chattering. It was, yeah, but it was transmitted on. That was.
It was intended for this thing,
Yeah.
yeah.
So in this case, we should next step we should transfuse the FFP
If
or
he is in a
something.
DIC,
After getting this,
according to
report,
tech,
what
we have to
from the
transfuse.
management point, what to do.
See, now we'll go again systematically. What when you came, there was some clue given because there was tachycardia. So probably that was the time where there was some blood loss. So you don't miss any clues. Okay, that is one thing. Second thing, you saw chattering, and on day 10 chattering, day 12 chattering is Either bleed or sepsis.
Sepsis.
Okay. You thought about it, but then you have to start working on that. Okay. Neither you work on sepsis nor you work on bleed. Okay. You're just thinking that can be a bleed. You have to actively work and see bleed where is. The common site of bleeding is going to be your GI bleed. Okay. You examine the patient also to start with, but you didn't examine to see whether there is a bleed, GI bleed. You just superficially examine the patient. So that is, again, you should avoid doing that, especially when you are suspecting bleed. Second, when there was a bleed, after that again, you didn't look for the bleed somewhere else that side. Okay, just a minute. Hello. So, you should have looked for other sites of bleeding. Okay. You look for even RT bleeds very late after taking gastroenterologist's opinion. Okay. That all thing has to be done simultaneously. You look for cannula site bleeding, hematuria, other any site of bleeding that you have to look. Okay. The commonest cause for this patient is 12 days. Probably is going to be more of a stress ulcer and bleeding from the stress ulcer. Okay. So, by scopy, whether you are going to choose something great, that is going to be dicey, but then you started with pantoprazole drip. Some people do prefer octreotide drip, so you can consider that. Whatever medical management you can plan to do that. Okay, that can be done. You stop heparin, gastroenterologists definitely don't want to do that. That's a routine clinical experience you got. You are going to get it when you even directly come into practice. Okay. Nobody is going to listen to you and will jump into procedure immediately. So that's a resistance going to be there, and you have to. And I want that you feel that natural resistance how, and you should know how to convince them.
Any surgical interference. Any surgical interference.
So you should know how to convince them. You could have called same gastroenterologist the next time, and you could have asked them that okay, yes, now coagulation factor we are corrected, apidity is normal, you please do it. He would still refuse to do it, then you should have just asked him, yes, suppose it lead to death,
Cannot let it happen.
then what will happen? So that was the question that probably will make him to think that yes, that's the correct way. So you still go politely, I don't say you dictate them, but say okay, this everything what is correctable we have corrected, it's still bleeding. There's no other options than to go and scope. We can speak to the family, tell them the pros and cons and risk involved in that. But I think we should go ahead. If you bleed to death, then probably that won't be a good thing to do. So that is what you can always tell him, and probably after listening to that, usually they get convinced. Okay. So that's the way you should go ahead. Okay. Doing tag, it was a good thing. You have done a tag. Okay. Tag was more of a, yes, mild. The clotting deficiency looks like mild. More of a R wave. R wave was almost around 13. Usually, even on ECMO with heparin, we keep it around 8 to 10. Okay. You could ask me heparinase tag. Okay. That would have been more clearer whether it is the excess of heparin which is causing a problem or whether it is a lack of clotting factor which is causing a problem. That could have been able, you could have been able to differentiate. Okay. So fine. Anything you want to ask me?
Fibrinogen levels we should have also.
Yeah, you have to do a complete workup.
Right.
You could have asked fibrinogen level. You could have asked the PTINR. So everything you have to work up completely when the patient is bleeding. But again, this was more of a local bleeding. But then also you have to work up completely.
Sir, first thing, as already we saw the Malina, so this RT section was necessary.
Yes. We don't know whether it is upper GI or lower GI bleed.
But sir, would it change your management currently? We are getting a Malina.
Yeah.
So we'll go with upper GI scopy only if we plan.
Yeah, but you don't want the blood to remain in the stomach, isn't it? If it gets too full, you have to decompress the stomach, it will aspirate. So all that is going to be, and then you will be able to know how fast is or what the rapidity of his bleeding. See, Malina is the one which is going to come afterwards. Okay. So if you see Malina now, is it that case bled fresh again? With RT will come to know, yes, he is bled. You have aspirated RT, now everything is clean. After 1 hour, if you aspirate again, blood comes, that means it's still bleeding. Yes. Malina, suppose you pass second time, third time, fourth time, is it that case still bleeding? No, it must be a collected blood, isn't it? So RT auspices, that's why it is very essential that you will come to know whether it is a bleeding continuously or no. Second, you have to decompress the stomach. If it remains in the, it will increase urea, it will remain in the stomach, then it will distend at the stomach, and then especially in pediatrics, okay. And then if he vomits and aspirates, okay, then again that's what new things that will come up. Yeah.
Secondly, even better than calling a gastroenterologist. From there itself you can say if there is upper GI bleed or not, that you could have said just by doing a simple procedure such as NG aspiration.
And becomes easier for you to even convince them, yes, he is continuously aspirating, continuously bleeding, so there is no other option than to go for a scopy. Even it might be negative scopy, but at least we can prove on paper that we have done a scopy.
You can wait up to 12 hours.
Yeah, you can wait. I don't say you have to jump. Till the time you don't correct the coagulative factor, you have to just wait till the time.
Second thing, sir, with this HB fall and shock, considering hemorrhagic shock, what would be a good strategy? Whether to stop the heparin, and second thing, whether we should continue heparin and give the product, or both of them together? Here.
The first thing, when he is bleeding actively, stop heparin. Till the time you diagnose what is the cause. Okay. Now when you feel that yes, the tag is too bad, okay, R is not that bad and tag clotting factors are deficiently, then definitely you can start with heparin and give clotting factors. Okay. But whatever the tag what I have shown you, I will just continue with stopping heparin. Would not like to give a product unless I would have proved that it is still bleeding actively.
So lysis 30 was high, so was there any role of tranexamic acid here?
That you can definitely consider. There might be some factor about fibrinolysis, and you can, in that you might give tranexamic acid. There is no absolute contraindication for tranexamic acid.
Clotting risk won't be there, sir?
Most of the papers says no, it doesn't increase it to a great extent. There are few papers which says there is a clotting factor after aminocapric acid, but the chances are, and tranexamic acid, but chances are less, not to great extent.
After all the surgeries, it is a routine to start on a tranexamic acid at least. So when there is a major bleed, definitely it is ideal to start on that. As a pediatrician, I thought when you started using it, you were giving lot of fluid initially. 300 ml has gone first and another 20 ml. So we calculate as per 10 ml per kilo, 10 ml per kilo, go by that. You could have used that volume in the form of blood products.
Yes.
Otherwise, patient will get overloaded.
To get blood, it will take time. So we have.
Can we do albumin instead of IV fluid, like crystalloids, in case of bleeding? Because that will give on contact pressure. And
not for that. If there is a volume problem,
right. We were stuttering.
Low albumin suggestion is there. Then again, when a patient is on ECMO, always you should be having the blood standby. When the patient starts, at that time you cannot go and ask for the blood. Sometimes we can encounter massive transfusion policies also. So at least 1 or 2 units of blood should be standby when a patient is on ECMO. They may not need that often unless there are emergencies, but you should have blood standby.
No.
Any questions?
No.
Any questions? We start from downstairs.
Downstairs.
If we
Who
have
was
to give
sleeping?
Any questions?
then we need to restart on heparin.
Not always necessarily, but it's more safer. Heparin and stopping both heparin and product is going to be more risky unless patient is bleeding too much and you have severe coagulopathy. You can wait. Otherwise, you should can give small dose of heparin, and when you are at least transfusing the protocol products. Okay. Otherwise, it will increase the risk of clotting.
I'm glad you had TEG, but even without TEG also, you should be able to manage the patient, as many of the units may not be having access to TEGs. Any questions, Vishal?
Hello.
Yes,
Sir,
please.
suppose same patient after 2 days, he's having bright red color from the RT aspirate. Do we need to call a gastro, or do we need to involve a interventional radiologist in this case?
First always the gastro and then the interventional radiologist. If gastro can do something, that's fine. If the bleeding is active, then you have to call an interventional radiologist. Again, interventional radiologist will be, the problem is going to be with interventional radiologist is, if there's an arterial bleed, he might be able to pick up. It's a venous ooze and diffuses, he may not be of, do anything. Okay.
Yeah.
So that is the last thing what we'll do it. But if the bleeding continues, yes, we have to do that.
The commonest is gastritis. Commonest. Other causes can exist, but commonest is gastritis to start with.
Okay, fine. Well done, thank you. So before you leave, one point you learn from this scenario, one by one.
So go back to basics, like start with clinical exam first, and then don't focus on only ECMO and machines.
Yes.
Focus on the patient also.
Focus on the patient, that is important.
Going systematically, one by one, clinical examination.
She said the same thing. I want you to say something else. There are so many learning points we discussed, isn't it?
Thus, we have to look for what is going wrong. Vitals itself, we can see here, this patient initially had tachycardia, then hypotension. From it itself, we can sense that there is something wrong. Maybe this hypovolemia is happening, maybe because of bleeding somewhere.
Okay.
So both of them.
There are many more things we spoke, isn't it?
Sometimes we have to argue with the opposite team. That's what we want to do.
Yeah, so you have to get your super specialist convinced that to do the procedure, because, and that's a common problem you are going to face when you go clinically. There will be a lot of reluctance, and then over a period of time you will know how to tackle them. I'm just giving you some tips how I used to manage my consultants.
Team approach as such. In your team should have understanding. Whoever came to me, I always mentioned about ECMO related radiology, ECMO related cardiology, etc. Similarly with the gastroenterology also, this is your normal reason for which you will ask for their advice. Have an understanding and let them understand heparinization and ECMO. So similarly with your neurologist, neuroradiologist, all these neurosurgeons, all these people, once you have a unit, related topics, the related subspecialists, they should be involved with this to the extent they are needed. You cannot call them when the problem happens, then it will take more time and more problematic. Before itself you discuss as a team and develop a team that is the right approach to go forward.
This reluctance are usually for 1 or 2 times. After that they also get confidence and they don't, the reluctance comes down. Yes.
Sir, I would say first of all we should not panic. Then history is important. Then teamwork definitely is important, and taking the advice of maybe seniors or even juniors is important.
Yeah. Okay.
Recheck again and again. Actually, we had examined this patient first, but we didn't get the point. Then again, we had seen that exposed. Then only we had seen the bleed. So
yeah. So
if
don't just superficially examine the patient. Do a thorough examination of patient. Just let it
problem
be
is
the
not solved. Then recheck again.
So everything has been told by them. Actually, mostly we need to see the patient thoroughly. And in this case, as the initial chattering, we thought is a hypovolemia, give the fluid, but it didn't came our mind that suddenly the patient might have bled, though it was not superficially, maybe internally. So that thought process, that reflexes is to be there.
So you have to go and find out the cause.
Find out the cause, why the chattering
Why the
happens,
chattering not just treating the chattering.
Not just treating the fluid down decreases.
Head to toe examination and teamwork will give better results.
Again,
better
that they
minds.
have told. You said something else. You tell something else. A lot of things we spoke, isn't it?
Anticoagulant.
I can still say you 5 things what I spoke.
So use blood products wisely.
Managing
Yeah.
different departments also.
That point also was taken. Yes. When you see one side bleed, you have to look for the other side bleed also. So see that case, whether it's a generalized bleed or localized bleed. Okay.
So start with the ECMO machine, go systematically, rule out. These are the areas which doesn't have problem, rule out. That way it would be helpful, sir.
Okay.
When we allocated as a team, we have divided our work. So when I was assigned, I was just looking for the tubing pipings. As everyone said, we did miss some important physical examination. The rest of the team, when there is no problem with the equipment side, they also can have a look on the patient side, rather than just watching the equipment. Because what we did was, I thought the tubings, everything is fine, there is no bleed, no leakage, and then miss the important part. The other team member can also have a look at the patient.
Yeah. So again, that is an important part that everybody should stick to their role, and everybody was jumping to the machine. That's not. And when the patient is on ECMO, it's not that case. There's only ECMO related issues. There can be a non-ECMO related issues that can also come up. You raised one point of DIC, isn't it? Have you investigated for DIC? Yeah, but the moment, why I'm asking this, whether the moment you thought about DIC, as I told you, there are 3 reasons for basically DIC to occur, or severe coagulopathy to occur. One is an hypothermia, second is your sepsis, and third is the circuit related.
Circuit was.
So you should have asked your ECMO people again to see whether there is any clot in the circuit, because that can be the cause for DIC. It was not there in this scenario, but I'm just saying. So whenever you think about DIC, look at the circuit, reconfirm that there is no clots in the circuit, because that is something which is going to be easy to treat. Clot in the circuit will lead to DIC. Okay. So that, because that clot is going to act for, it will act as an nidus, and that will consume the clotting factors. Okay. Thank you.
Thank you, sir.
Thank you.
Thank you.